Hello, colleagues. My name is Omozeli Inobosi. Today, I am presenting evidence-based research on the early outpatient management of hyperemesis gravidarum, as this poster shows, based on my Assessment 3 PICO findings. We as nursing professionals can observe every day the problem of women who are pregnant and have severe nausea and vomiting that go way beyond ordinary morning sickness. This study shows that we can make notable changes to improve maternal outcomes using evidence-based practice. Hyperemesis gravidarum has been identified in thousands of women each year, with the most common cause of reactive and emergency-based methods found to leave patients in needless suffering. We can reform care daily and become leaders in improving maternal outcomes by examining early patient interventions. Diagnosis explanation. Hyperemesis gravidarum impacts 1 to 3% of pregnancies, although it has severe life-changing effects that go well beyond the normal pregnancy distress. In contrast to morning sickness, hyperemesis gravidarum is accompanied by severe pathologic nausea and vomiting that result in acute risk to women characterized by dehydration, electrolyte imbalances, malnutrition, and weight loss of more than 5% of pre-pregnancy weight. Such complications as Wernicke's encephalopathy due to thiamine deficiency, acute kidney injury, venous thromboembolism, or maternal death in the worst case scenario are serious. The psychological ramifications are just as bad, and they include depression, anxiety, postpartum stress disorder, and suicidal ideations that might continue even after pregnancy. These risks are significantly increased by healthcare disparities that can affect vulnerable groups. Young mothers, racial minorities, and low-income people are exposed to systematic barriers such as late diagnosis, poor access to treatment, and provider bias that dismisses their symptoms as a normal part of pregnancy complaints. These differences make up a vicious cycle in which those most at risk get the least prompt response, resulting in avoidable complications and less favorable outcomes. The economic cost is high, and emergency visits to the hospital, readmission, and low productivity impact families and healthcare system. Also, a significant number of women develop PTSD related to pregnancy and make decisions not to get any more children in the future, which will affect family planning. PICO question breakdown. P for population. Our target population is pregnant women with hyperemesis gravidarum, severely experiencing some symptoms, and medical intervention is needed. I, intervention. Outpatient IV rehydration and antiemetic therapy are accessible as they offer early proactive care in clinic settings, which can be administered before the symptoms become life-threatening. C, comparison. Routine emergency department-based care represents the current reactive measures, where patients can only turn to receive help in case of emergency-related cases. Outcomes. Symptom relief, reduced hospital admission rates, and improved quality of life directly impact patient experience and healthcare utilizations. T, time. The first 16 months of gestation represents the critical window when hyperemesis gravidarum symptoms peak and early intervention yields maximum therapeutic benefits. PICO criteria explanation. The PICO question meets all evidence-based practice criteria by establishing a clear, answerable clinical question that guides systematic literature review, and practice change implementation. The population is specifically defined with inclusion criteria enabling targeted intervention strategies. The intervention is measurable and implementable within existing healthcare frameworks, while the comparison represents current standard practice, allowing for meaningful outcome evaluation. Outcomes are patient-centered and measurable through validated assessment tools and healthcare utilization data. The time frame provides specific parameters for intervention, timing, and outcome measurement. Evidence summary. My comprehensive literature search yielded 4 high-quality sources from prestigious medical journals addressing assessment 3, feedback regarding evidence levels and credibility factors. Van der Minen et al. Of 2025 from the International Journal of Gynecology and Obstetrics represents level 6 evidence through expert opinion with a narrative review authored by international collaborators from Amsterdam, UMC, providing global hyperemesis gravidarum management perspectives. Jensen et al. Of 2025 from the Canadian Medical Association journal constitutes level 6 evidence as clinical expertise and expert committee recommendation with authors who developed the Windsor criteria for hyperemesis gravidarum diagnosis, establishing them as international authorities. Mars et al. Of 2022 from BMC Pregnancy and Childbirth provide level 6 evidence through a cross-section survey analysis of 786 participants, offering valued patient-reported outcomes data. Martinez do Tejada et al. Of 2024 represent level 7 evidence through expert opinion based on clinical experience and literature synthesis. These evidence levels are appropriate for hyperemesis gravidarum research because ethical and practical constraints limit randomized controlled trials in pregnant populations. All sources have a high level of credibility factors such as MD or PhD qualifications with obstetric experience, publication in high-impact peer-reviewed journals with high review requirements, multi-institutional international cooperation promoting validity, recent publication rates ensuring high relevance, and a high level of proving ethical principles of research and methodological integrity in their overall analysis. Evidence analysis. The evidence overwhelmingly supports the early outpatient intervention of hyperemesis gravidarum due to convergence in finding across all sources. The most notable ones are the habit of patients strongly preferring outpatient settings to emergency department visits, as patients are more satisfied, feeling greater autonomy, and have better continuity. Clinical effectiveness is demonstrated through early IV fluids and antiemetics, which prevent progression to severe complications requiring hospitalizations, while prompt thiamine supplementation prevents Wernicke's encephalopathy. Structured outpatient protocols have repeatedly been shown to decrease healthcare utilization as well as achieve higher clinical outcomes and even greater psychological improvement through the elimination of anxiety caused by unpredictable emergency care setting. The evidence conclusively proves that early outpatient IV rehydration and antiemetic treatment is better than the emergency department-based approach to managing symptoms and relieving patients of hyperemesis gravidarum in the first trimester of pregnancy. Care steps. Based on this evidence, 4 significant care steps are suggested to be implemented to begin with early screening and evaluation with the help of the PUQE scoring system allows objective evaluation of symptoms and uniform monitoring over time. Second, organized protocols of outpatient IV therapy must develop programs in clinics where hydration is provided with normal saline, potassium supplementation, and first-line antiemetics, all in a single day. Third, they should not be given any IV dextrose without prevention supplementation of thiamine that may cause complications of Wernicke encephalopathy. Fourth, patient education and care coordination must be extensive to provide resources, define follow-up procedures, and guarantee seamless communication between settings. The BSN educated nurses can drive this campaign with extensive evaluation skills, patient education knowledge, and care coordination skills leading to early detection, outpatient procedures promotion, and continued care experience across health facilities. Conclusion. This evidence-based analysis proves that early management of hyperemesis gravidarum in outpatient care would be the best form of outpatient treatment and optimal use of sources. BSN-trained nurses have the clinical expertise, patient advocacy abilities, and leadership capability to revolutionize hyperemesis gravidarum care delivery by developing protocols, quality improvement activities, and patient-centered care strategies that would drastically change the outcome of this susceptible maternal group. References: Jason, LAW, Shaw v. Grutin IJ, Kut, M.H. Dean, CRO and Painter PROC of 2024. Diagnosis and Treatment of Hyperemesis Gravidarum, Canadian Medical Association Journal, 19614 E477 E4485. We have Mers, Aromoro, A, Shonway, Hayes Zapata, I. Frostain D, and Brooks of 2022, Assessment of Management Approaches for Hyperemesis Gravidarum and Nausea and Vomiting of Pregnancy, a retrospective questionnaire analysis, BMC Pregnancy and Childbirth, 2022. Martinez de Taja of 2024, Nausea and Vomiting of Pregnancy, Hyperemesis Gravidarum, European Journal of Obstetrics and Gynecology and Productivity Biology. Minim LM Vander of 2025, The Impact and Management of Hyperemesis Gravidarum, Current and Future Perspective, International Journal of Gynecology and Obstetrics. These are my references. Thank you very much for your time.